It's a long chapter, a very important chapter. Though nowadays incidence to some extent less. During our house substitute time, we have got large number of cases of acute rheumatic fever. It means acute, that is, it occurs within very short time, within 1 month. Any disease occurring within 4 weeks is called acute. So it is acute. Giving rise to rheumatic fever, that is. Okay, let us start with a case. How they usually present. It is an illustrative case how the case of acute rheumatic fever usually presents in OPD or IPD. Now, this is a 12-year-old female. 12-year-old female. Remember, the rheumatic fever is more common between the 5 years to 15 years. So, if everybody asks you what is the most common age of rheumatic fever, is the 5 years to 15 years. 5 to 15 years of age. Is it more common on female? In female, answer is yes, it is more common in female rheumatic fever. The reason is not known why, but it is more common in female rheumatic fever. So this, now, what is the presentation in this case is the high grade fever for last 7 days. So fever is a very important manifestation of rheumatic fever. Remember, the fever is usually high, more than 38.5 degrees centigrade, and this fever is present from the first day of the rheumatic fever. Not in all cases fever is present, 60 to 70% cases. In 60 to 70% cases, out of 10 cases, 7 cases you will get the fever is the onset of disease. So this child present with the fever. Next to go, the 5 days after the onset of fever, the child develops pain and swelling in multiple joints. So this is very important findings in rheumatic fever. So pain and swelling in multiple joints, that is multiple joints are affected in this disease. What is the nature of these joints? They are usually large joints like ankle joints, knee joint, elbow joint, shoulder joints, etc. Large joints. Now joints are affected in other diseases also. For example, a child is suffering from viral fever, there may be involvement of the joint pain. And you also suffer from viral fever and you have seen that there are pain in the joint. So joint pain is a common manifestation, or arthritis may be a common manifestation in viral fever. So it may be a case of viral fever also. So joint arthritis or joint pain are not similar. Arthritis means when there will be pain along with the swelling of the joint. That is, sign of inflammation should be there. Swelling, tenderness and pains are present. That is called arthritis. Arthalgia means only pain. There is no swelling or edema or redness of the joint. So in this case, we are seeing that the child is multiple joints, starting with the left knee and then migrating to the right knee, ankles and wrist. This is very important character of acute rheumatic fever. The joint pain or arthritis is migrating in nature. That is, it is occurring in the elbow joint, then it occurs in another elbow joint when this elbow joint is normal. So arthritis is migrating as if it is moving from one joint to other. It is migrating arthritis, and it may be polyarthritis usually, but in endemic country like us, monoarthritis may be also be presentation. Usually rheumatic fever is polyarthritis, but in our country it may be monoarthritis also. Now past history non-contributory in this case, family history also non-contributory in this case. So we are starting again and we have illustrated with the case, and this is a case name X, the name is hidden, age is 12 years. So age is important in a case of acute rheumatic fever. Usually it is common in between 5 to 15 years, though it may happen after that or below that, but it is most common during the range of 5 to 15 years. Here the case 12 years. Next, sex is female, so it is more common in female, but it may occur in equally or slightly less in male, particularly rheumatic heart disease, they are more common in female. So, here the address is Bolpur. Now, they usually come from the low socioeconomic status where there are chances of overcrowding. It means in a room, say more than say 4 or 5 persons are living. Overcrowding, poor sanitary conditions in those areas, that is, they are usually present. And their usual chief complaints starting with the fever, and there may be second is a joint pain, and in this case there is shortness of breath and chest pain for 3 days. Now remember, fever is a common finding, common clinical symptoms of rheumatic fever. Joint pain is very important, and this joint pain is usually the involvement in the large joints, and if you examine the joint, you will see the joints are swollen and they are very much tender and they are red in color, edematous also. That is called arthritis. When there is pain in the joints, that is called arthalgia. When the joint pain is associated with swelling and edema and redness, that is features of inflammation, it is called arthritis. In rheumatic fever, we will get both arthritis and arthalgia. I will show you where you will get the arthritis, where you will get the arthalgia. Okay? So, arthritis is a common presentation of rheumatic fever. You will get in say 60 to 70% cases of acute rheumatic fever, you will get the arthritis the presentation. Usually it is not the large joints, not the smaller joints. The large joints are usually involved, and like say ankle joint, knee joint, and the elbow joints, etc. And the facial character of the joints are joint swelling are they are migrating in nature. It means the one joint swelling, one joint is affected, then after that another joints are affected, and during that time the previous joints is becoming healthy. Remember, joints are affected, but they are not damaged in rheumatic fever. This is very important. Whereas in rheumatoid arthritis, where the small joints are affected, and occasionally large joints may be affected. But in rheumatoid arthritis, where the small joints are affected and occasionally large joints may also be affected in different varieties of rheumatoid arthritis, there are chances of deformity. But that type of deformity does not occur in case of rheumatic fever. Is it clear to you? Next important thing is that now this type of joint swelling and joint pain you will get in other diseases also. I have mentioned you the rheumatoid arthritis, but you can get it in rheumatoid arthritis means juvenile. Nowadays it's called juvenile idiopathic arthritis. Juvenile idiopathic arthritis terminology should be used. You will get this type of joint swelling, maybe small joints but maybe large joints. But specifically if it is not juvenile, then small joints are affected in rheumatoid arthritis. Next, go to the another case is viral fever. In viral fever, you will get this sometimes you will get the arthritis like manifestation in viral fever, or in case of some reactions, allergy reactions, say serum sickness reactions, you will get the arthritis manifestations. Okay, so arthritis is not solely manifestation of rheumatic fever, you will get in other cases also. Now, if there is involvement of the say in this case there is a palpitation is there, the shortness of breath is there, it means there is some affection of the heart. And this is very important thing you see, look at this picture, there is a history of a sore throat about 3 weeks ago which was not treated with antibiotics. So this sore throat usually caused by there are lots of other causes. Most common sore throat cause is virus, but sometimes the sore throat may be caused by group A beta hemolytic streptococcus, GAS. So streptococcus infection sometimes it may give rise to sore throat, and if you do not treat the sore throat within 9 days of affection, there are chances of rheumatic fever. That does not depend only on the no treatment, it also depends on the genetic capability and the strain of the bacteria which is giving rise to sore throat. Usually there will be different strain of which the only M strains of the different varieties of M strains they are capable of giving rise to rheumatic fever. So sore throat is very important past history whether it is present or not. Usually there is history of sore throat present before 3 or 4 weeks of onset of rheumatic fever which is not treated properly. The reason is that when there is sore throat, the body will try to resist the infection or kill the bacteria by producing antibodies. Okay. Now these are, how the body is produced by antibody? Because streptococcus antigen gives rise to stimulation of the T cells. First they are engulfed by the macrophages, then macrophages carries the antigen to the T cells, then the T cells will stimulate the B cells and B cells will convert it to plasma cells and they will produce antibody. So antibodies which are produced against the streptococci, these antibodies will attack the streptococcal antigen or the protein which are similarity with the streptococcal antigen. There are, in our body, human body, there are some structures which has some similarity with the streptococcal antigen. These structures are, number one, is the cardiac structures, cardiac myocardium, endocardium or pericardium, and number two, there may be joint structures, synovial membrane, and there is on the skin, there are also some antigens are present where they are affected. These antigens are also present in the basal ganglia of the brain. So antibody they will pass to the different areas and give rise to damage to that area. If it attacks the heart, say myocardium or heart muscles, then it will give rise to myocarditis. If it attacks the endothelial lining of the heart, endocarditis, and if it attacks the pericardial layer, pericarditis. Similarly, joints, synovitis, joint swelling, edema, and in the skin that gives rise to different type of skin lesions that I will show you, and it can give rise to involvement of basal ganglia also attack. That can give rise to some abnormal movement of the due to attacks of these antibodies. So that may occurs. So this is important. Why this? It is called molecular symmetry. Molecular symmetry. These antigens are common. That's why the damage is occurring. Some people believe that probably some toxins are released from the bacteria and that toxin is damaging these structures. That is called cytotoxic theory, but that is not accepted by all. Now, past history, nothing contributory in this case. Family history, nothing contributory. Now, socioeconomic status, you know there is a poor socioeconomic status of overcrowding present. These are very important predisposing factors for onset of streptococcal infection. Suppose I am suffering from streptococcal sore throat, another person lying very close to me, the chances of suffering from that state of infection. Otherwise, the things are normal. Definitely, these are all expected. There will be tachycardia. You see the tachycardia is there. Pulse rate is 120 beat per minute and temperature is 101.5. So, per degree rise of temperature, we usually expect there will be heart rate will be increased by 10. Per degree rise of temperature above the body temperature, normal body temperature, heart rate should be increased by 10. Okay. So, if I consider the heart rate, the average heart rate is 72 per minute, then and average say body temperature is 98.4 say degree Fahrenheit. In this case, 101.5 or 101.4. So only there is 2 or 3 degree. So 30 heart rate should be increased. So it should be 100. 72 plus 30, that is 102 per minute. Or here the heart rate is 120 beats per minute. It means this is called relative tachycardia. Relative tachycardia, it means where the heart rate is more, tachycardia is more than expected. Relative tachycardia. It is also one common findings of acute rheumatic fever. Now these are the normal places, normal observation. This is present. In this child, this is present. This is called erythema marginatum. Erythema means redness, marginatum means marginal redness, and central is pale. Erythema marginatum is one of the important manifestations, and it is not persistent for a long time. It is usually found in fair complexion. যারা খুব ফর্সা তাদের পায়, not very common in dark skin, and it will disappear after that. Joints discussed before, these are the joints manifestations. This is increased joint inflammation along with the other things. These rashes are associated findings, this is not common. Heart sound, we got some murmur, rough, absent, others are normal. We will discuss these things later on. Neurological examination, nothing abnormality, it is normal in this case. Investigation we have done. Now, WBC total count is elevated. So, in a case of rheumatic fever, it is expected the total count will be elevated. Okay. ESR, as inflammatory reaction, immunological inflammatory reaction, so it is expected that ESR and CRP, they will be elevated or high. Inflammatory reactions. So ESR is high and CRP is also raised. And throat swab culture is detected as streptococcal pyogenes group A streptococcal infection. ASO titer, it is elevated. Remember, the throat swab, as the disease occurs after 3 to 4 weeks of onset of streptococcal infection, you may not get throat swab positive always. But still you have to do the throat swab culture. If you get it positive for streptococcus, it is your proof that there is history of streptococcal infection. Okay? And other than that, if you do not get it, then this will suffice. There is ASO titer, anti-streptococcal O titer. There is antibody against streptococcal O, or anti-DNase B, that is also another antibody. Those levels will be higher in the rheumatic fever. Cardiac evaluation, we have got these common findings in rheumatic fever, particularly mitral regurgitation. Mitral regurgitation is clinical findings as well as echocardiography findings. Remember, if you get the clinically mitral regurgitation findings in the case of acute rheumatic fever, it indicates there is carditis. If you do not get clinical mitral regurgitation murmur, but other features of rheumatic fever are present, and echocardiography is showing that there is mitral regurgitation, this is called subclinical carditis. Subclinical carditis. So clinical carditis means where you are getting clinically, subclinical means where the echocardiography shows the murmur, but you are not getting clinically the murmur. Okay, subclinical carditis. So this is diagnosis of acute rheumatic fever. This is in nutshell the case which we have got, and then we are getting the discussion of our topic. That was a case which I have discussed. Now this is discussion is our topic. I think it is common to the acute rheumatic fever immunological disorders. You will agree after the discussion of the case, and it develops after this group A beta hemoglobin streptococcus infection. Common age group I have discussed 5 to 15 years of age, and prevalent more in low socioeconomic countries. Definitely, fine. Now, what type of response it is? Delayed autoimmune response, not immediate. Just like say acute reaction, taking a food and there is severe urticaria, this is called acute reaction. It's a delayed reaction. And response is for rheumatogenic strains of group A streptococcus to susceptible person. I have told you that not all person will be affected by that. Only persons who are susceptible as well as who have some molecular mimicry, that they can give rise to rheumatic fever. Now there is a pathological stages. There are 3 stages, definitely just like all other inflammation. Right? First stage is stages of, you see the first stage, pathological stages, exudative phase, the swelling, edema, etc. exudative phase. Second phase, polyphytic phase. It means there is some say fibrosis, there is some say conversion of the histiocyte known as ASOPs nodules, they will form, and Aswab's nodules is the pathognomonic of rheumatic fever as per pathology is concerned. Okay. Now, after this stage, there is fibrosis stage. If it is not controlled within this stage, there is some damage of the fibrosis will be there. So, damage of the different structures. Only structures which is mainly damaged as heart. It is mainly got in myocardium, maybe in the other structures also, but mostly it is central necrosis surrounded by macrophages and epithelial cells. তো পড়ে স্যার কত পড়বে, বেশি পড়লে মাথা ব্যথা খারাপ হয়ে যাবে। So there are some criteria by Dr. Jones, Major Jones. This criteria first published in 1946, subsequently modified in 1960, then 81, 82, and lastly it is modified in 2015. This modification comes after the one Indian lady, Dr. Vijayalakshmi from Chennai, Dr. Vijayalakshmi, and Madam is the mother of cardiology in India, and Vijayalakshmi published a book. There is a heart disease book, and Vijayalakshmi states that not the clinical mitral regurgitation, if the mitral regurgitation present in the echocardiography, along with the features of rheumatic fever, it should be considered as rheumatic carditis. This is the observation of Vijayalakshmi. And that is accepted. After that, there is some modification, latest modification or revised modification 2015, and you will see this modification. Here you see the American Heart Association accepted that criteria, and it is accepted throughout the world, not only America, but throughout the world is accepted. The two groups are there, low risk population, high risk population. Moderate or high risk population means acute rheumatic fever incidence is more than 2 per lakh, or prevalence is more than 1 per 1,000. This is high prevalence. Remember, rheumatic fever you should know in details. Okay. Low risk population means rheumatic fever less than equal to 2 per 1 lakh, or prevalence is less than 1. It is very easy to remember. Yeah. Total population and prevalence. Very easy to remember, the formula is easy. Now, major criteria means main criteria. There are two criteria, major criteria and main criteria, along with some evidence of streptococcal infection. These are the three things we will have to observe: major, minor, and evidence of recent streptococcal infection. So let us go to this. Moderate and high risk and low risk. Is clinical or subclinical carditis same in both cases. Now, carditis present in around say 60 to 70% cases, or say average 60% cases of acute rheumatic fever. Not all cases suffer from carditis, and not all carditis will produce the rheumatic heart disease. Rheumatic carditis and rheumatic heart disease are different. Rheumatic carditis means when the disease is acute in onset. Rheumatic heart disease means disease is past and now there is some lesions in the heart, which is a consequence of previous rheumatic carditis. That is called rheumatic heart disease. Now, there may be some valvular damage, there may be some stenosis, etc. These are rheumatic heart diseases. Now, clinical or subclinical carditis, subclinical means where only echocardiography findings is present, but clinically not getting the murmur. Okay. But the other features like rheumatic fever or like the enlargement of the heart, cardiomegaly, that you will get. Like tachycardia, dilapic tachycardia, you will get. Or features of sometimes not common, that is the cardiac failure. Rheumatic carditis is usually pancarditis in nature. It means there is the involvement of the pericardium, involvement of the myocardium, involvement of the endocardium. When the pericardium is involved, pericarditis, there will be some pain in the chest, just like in our patient. It presents the pain in the chest. So that is not persisting for the long time, because in the pericarditis, there will be immediate after the inflammation, there will be accumulation of fluid, small amount of fluid in between the pericardium that will cease the pain on the heart. And very lucky person can get pericardial rub pericardial nerve due to friction of the pericardium in the acute pericarditis stage. Rheumatic myocarditis means involvement of the myocardium, and when the myocardium is involved, then what is happening? There is some edematous conditions and swelling of the myocardium, and there will be dilatation of the or enlargement of the heart. So cardiomegaly may be a manifestation. At the same time, in the myocardium, when it is involved, the valve which are attached to the myocardium, as it is involved in enlargement, there may be some regurgitation. There may be some regurgitation murmur is there. Okay. So mitral regurgitation is a common findings of rheumatic heart disease, rheumatic carditis, clinical findings. Previously, during our time, it was thought if you do not get the clinical mitral regurgitation, you should not diagnose it as rheumatic carditis. But now the concept is changed. There will be another things which may happen. We have discussed about the myocardial involvement and giving rise to mitral regurgitation. Now, suppose the mitral valve is swelled. There is swelling in the mitral valve along with the heart. And this mitral valve swelling, there is thickening and swelling of the mitral valve can give rise to some narrowing of the mitral orifice also. That narrowing gives rise to some sort of narrowing of the mitral valve, give rise to some sort of flow of the blood from left atrium to right atrium during diastole. During diastole, blood will flow from the left atrium to right atrium, and swelling of the mitral valve giving rise to relative mitral stenosis. It is not the true mitral stenosis. Never say that mitral stenosis. There may be some mid-diastolic rumbling murmur flow of blood from the left atrium to the left ventricle due to swelling of the valve. That may also be a findings. That is called Carey-Coombs murmur. Remember, this is not very important murmur, and Carey-Coombs murmur, which is first mentioned in 1986, it is not accepted by all. So I think you should forget about the Carey-Coombs murmur, but till the latest edition of books, they are mentioning the Carey-Coombs murmur. It is not accepted by all, but as the latest edition of different textbooks are mentioning this Carey-Coombs murmur, I have mentioned this. This is not important. What is important is the regurgitation murmur of mitral regurgitation. Okay. Now go to the next point after the carditis is the polyarthritis, moderate or high risk. We previously discussed about the polyarthritis. Now here the change. Monoarthritis. This means arthritis may be single joint also. In case of high risk area, suppose in India, we should consider even the single joint is affected along with the features of rheumatic fever. So monoarthritis, this is the change which was not present before. And polyarthalgia, that is pain in the joints, not swelling. Arthritis features are not. These are accepted now as a major criteria. It was not present before during our time. I think তোমাদের সময় তো ছিল না বোধহয় নাকি এসে গেছিল তোমাদের সময় তো এসে গেছিল জাস্ট তখন হ্যাঁ ছিলই না একদম 2015 একদম ঠিক আছে so this is coming in high risk zone but where is a low risk zone there they only mention polyarthritis only. Now the rest of the thing like say chorea present in both the cases. Chorea also say chorea is due to affection of the basal ganglia. I have told you that there are some antigen present in the basal ganglia which is also get attacked by the antibody and that can give us damage. But it is reversible in nature. It is after 3 or 4 months it is reversible chorea. So we will go to that point. Edema margentum you have seen that is also very important point but very difficult to detect in our country because we are black skinned. Only fair skin. Subcutaneous nodules, some nodules present in the extensor aspect of the body, like say wrist, elbow, knee, scapula, spine, you will get some nodules are there. These nodules are non-tender in nature and They are movable in character. They are called subcutaneous nodules. Very pathognomic or major criteria of rheumatic fever. Remember these things like Major Jones criteria is applicable in all these cases, but even if a patient with only carditis, no other features of rheumatic fever, in that case, if you get the previous history of streptococcal infection, like say ASO titer or anti-DNase B titer is increased, you should stamp it as acute rheumatic fever. So in case of rheumatic carditis or in case of chorea only, even if other features are not present, you should stamp it as acute rheumatic fever. This is an exception to the rule. In all other cases, you should follow this, except the chorea and subcutaneous nodules. And nowadays, erythema marginatum, because it is not seen commonly, but in other countries, erythema marginatum is common and they can detect also. There are some minor criteria also. You see the minor criteria. Here you see the high risk group monoarthalgia. Here is the low risk group polyarthritis. Fever present in both the cases, fever, ESR rest, CRP rest, present in both the cases and prolonged peer interval. They are present in both the cases. The differential diagnosis, we have discussed about the juvenile idiopathic arthritis or rheumatoid arthritis and reactive arthritis. Suppose an adolescent suffering from some sort of say severe UTI or say bacillary dysentery, or sometimes small child is suffering from some say diarrhea, that can give rise to some arthritis. That's called reactive arthritis. Now you see the viral arthritis, we have discussed this, and bacterial infection can give rise to arthritis like say salmonella arthritis, then monoarthritis can give rise to this. Tuberculous arthritis has some special nature, so though anybody can tell it, but it is not very good differential diagnosis in this case. Similarly, the scab type is sometimes present with the features of polyarthritis, the rickettsia. So they will come in this profile, and collagen vascular disease, like say different types of collagen vascular disease, SLE and other things, they may present with arthritis and other manifestations of that disease. These are the important disease, but lots of other diseases are there. Suppose there is some traumatic arthritis, septic arthritis, tension bacterial arthritis, and some set of immunological arthritis, there is serum sickness syndrome, so they will come in differential diagnosis. This is just, we have discussed that the carditis, 60% of cases you will get it, and you see the recurrent attack of acute rheumatic fever give rise to more and more involvement of the carditis. So, if one carditis occurs and if the repeated infection is going on, repeated rheumatic carditis occurs, then there are more chances of damage of the valve. That's why you should prevent this. You should prevent the recurrent attack of rheumatic carditis. Okay? So, prevention is very important. That is called secondary prevention. Acute rheumatic fever ARM is there, but you should prevent it by giving some treatment for prevention of recurrence. Otherwise, there is every chance of damage of the heart. These are the consequences of rheumatic fever, say this, and I have discussed this. Polyarthritis, you see, we have discussed that the same thing, we should not mention. Chorea is important. Chorea not present in all these cases, only 10 to 15% cases will get chorea. It means some say Saint-Vitus's dance, it is also called. There is some say different types of tone. Chorea is caused by the hypotonia of the protagonist and antagonist muscles simultaneously, and due to involvement of the caudal nucleus. So caudal nucleus is involved in a case of chorea. It is called Sydenham's chorea. There is another chorea known as Huntington's chorea. There may be another type of chorea which may occur in Wilson disease. In all these cases, Huntington chorea is autosomal dominant in nature. Wilson disease, you know that it is also autosomal recessive in nature, but it is affected due to defect in copper metabolisms. So chorea in differential diagnosis will come on rheumatic heart disease, rheumatic fever, Wilson disease and Huntington's chorea. They will come in differential diagnosis of chorea. Now, this is the some movement of the limbs. Movement of the limbs due to alteration of the muscle tone is chorea. And if you see the patient, you will see that it's quasi-purposive in nature. You will think that the quasi-purposive, you will think that the patient is doing it voluntarily. Actually, he or she is not doing it voluntarily, but you see the voluntary movement. Abnormal movement. I will show you that movement of chorea. This is that chorea. You see the coriform movement there. This is the chorea. Involvement of the basal ganglia is there. These are different type of movements, others. Now there are some features due to different type of tone. These features are may be asked. Those who can give good answer these features, they may be asked. First thing is that milkmaid's grip of the fingers. That is, if you take the fingers of the patient, that the grip is like this. Sudden tone is increased and sudden release of the tone. Variation of the tone. Milkmaid grips. Spooning and pronation of the hands when the patient's arms are extended. এইভাবে তুমি হাতটাকে বাড়াতে বললে হাতটা বাড়িয়ে এইভাবে ঘুরে গেল স্পুনের মতো এগুলো আর প্রোনেশন মিলমেট গ্রিপ আঙুলটা ধরেছো তার কন্ট্রাকশন রিল্যাক্সেশন সেই গোয়ালাদের দুধ দেওয়ার মতো অবস্থা টানছে একবার ছাড়ছে তাই তো দ্যাট ইজ কল্ড মিলমেট গ্রিপ দ্যাট ক্যান অকার থার্ড ওয়ান ইজ টাং জিপটাকে বাবা বের করবে ঢোকাবে ভেতরে বুঝেছো ডার্টিং মুভমেন্ট অফ দ্য টাং হ্যাঁ জিপটা বার করবে ঢোকাবে এরকম টাঙের মুভমেন্ট অ্যাবনর্মাল মুভমেন্ট অফ দ্য টাং আর ইফ ইউ টেক দ্য হ্যান্ড রাইটিং স্লাইডটা একটু ইয়ে হয়ে গেছে হেঁচিয়ে রাখছে ইফ ইউ টেক দ্য হ্যান্ড রাইটিং উইল বি বিজারি ইন নেচার স্ট্রেট হ্যান্ড রাইটিং হবে না all these are due to variation of the tone. So milkmaid's grip, contraction, relaxation, milkmaid grips, pronation, হাতটাকে এক্সটেন্ড করছো পনে ঘুরে যাচ্ছে pronation, ঠিক আছে হয়েছে these are the important things will be did. And these are due to alteration of the tone of protagonist and antagonist muscles due to involvement of the caudal nucleus. Movement of the tongue is also abnormal in chorea and handwriting is also altered. Subcutaneous nodules I have discussed where the disease may be present. They are non-tender or mobile in nature. Now, after the finishing of the clinical features, you should know the diagnostic criteria. These are the important changes in the diagnostic criteria that you see. This is Jones diagnostic criteria. So you know about the modified Jones criteria, you know the every clinical features, then you go to the diagnostic criteria. First episode, two major criteria, if present, it is diagnostic. Or one major and two minor, it is diagnostic. But in every case, there should be evidence of streptococcal infection. ঠিক আছে সেকেন্ড দেখো রেকারেন্টে কি আছে টু মেজর অ্যান্ড ওয়ান মেজর আগের মধ্যে জাস্ট লাইক প্রিভিয়াস ওয়ান মেজর প্লাস টু মাইনর জাস্ট লাইক প্রিভিয়াস দিস ইজ অ্যাডিশন ইন দ্য রিসেন্ট থ্রি মাইনর ক্রাইটেরিয়া ইফ দ্য থ্রি মাইনর ক্রাইটেরিয়া আর প্রেজেন্ট সাপোজ ফিভার arthalgia or raised CRP or say PR interval increase, three minor criteria present, along with the recent streptococcal infection, you can diagnose here rheumatic fever. Exception I have told you chorea and carditis. Indolent means just only presenting with the carditis. Evidence of recent streptococcal infection means ASO titer, anti-TNS B or positive throat culture that is discussed. The treatment is made actually treatment is done to reduce the inflammation only. Most important thing is in this case is prevention is very important. Okay, prevention is very important. Now here the treatment, suppose the polyarthritis is present, so you should reduce the pain of the child, because it is very much painful, and so you should give it polyarthritis. And those with carditis without a cardiomegaly, it means heart size is normal or there are no signs of failure. In that case, you give only salicylate. And dose of the salicylate is usually low, 50 to 70 milligram per kg in 4 divided doses orally. 3 to 5 days, তারপর again 3 weeks, 3 days, 3 weeks, 50 milligram per kg, and then half the dose another 4 weeks. These doses are dramatically changed. Previous dose was 90 to 100 milligram per kg. Now the dose is almost 50%. 50% of the dose. In the previous thought, dose should be continued for the same week, 4 weeks, or say sometimes 12 weeks, etc. But this is not so. Only till the ESR and CRP are normal, the inflammatory process is, when the inflammatory processes are normal, you will have to continue the aspirin doses. And that is usually 2 to 4 weeks in low dose. Okay. Next, we go to the patients with carditis, cardiomegaly, and or failure. In those cases, you should start steroids, penicillin. So, where there is a carditis with failure, in that case, you should give steroids. Or cardiomegaly, patients with carditis without failure, you should give steroids. Steroid dose you see 2 milligram per kg, 2 to 3 weeks, followed by half the dose for 3 weeks, and then reduce the tapering dose every 2 to 3 days. So you should remember this. Sometimes it may be happens. And when you taper the penicillin to prevent the relapse, to prevent the inflammation, when you taper the penicillin in the last line, tapering, during that time you should add aspirin also. And that should be continued for another 6 weeks. Okay. And previously it was thought probably the digoxin should not be given, diuretics should not be given in case of rheumatic carditis with failure. But now the thought is changed. Now it is said that if there is failure in a case of rheumatic carditis, cautiously you can give digoxin cautiously, because if there is myocarditis, then digoxin may be harmful in that case. So cautiously you should give digoxin. You can use diuretics, etc., but with some caution or continuous observation. It's the latest change. 2025 change. In the last edition also, there is a digoxin only 1 dose may be given, diuretics 1 dose may be given. These are not accepted now. This is the latest revision. So primary prevention means when there is infection just started, before 9 days you give some antibiotics. Either benzathine penicillin or penicillin B or amoxicillin or azithromycin, etc. Okay, but remember this is a major decision you should take, because majority of the doctors, if there is any sore throat, they start antibiotics. But most common cause of sore throat is viral infection. So there is antibiotics misuse of antibiotics. In that case, you can say a quick diagnostic test, rapid diagnostic test for streptococcal antigen, or you can send it for culture sensitivity. And then you start antibiotics, because you have 9 days in hand. You have 9 days in hand. Within 9 days, if you give the primary treatment like this, which is written there, if you give that, then it can prevent the acute rheumatic fever. That is called primary prevention. Secondary prophylaxis is very important, because once the carditis is developed, if you do not give the secondary prophylaxis, repeated carditis will occur, and that can give us to permanent more and more damage. So here you see the weight is important. During the middle time, weight is lifted out, but now weight is again coming. Less than 27 case, 6 lakhs unit, more than 27 case, 12 lakhs units. This should be every 3 weeks. Every 3 weeks it should be given. First line, there is a mistake, that is here, D by M at 12 lakh, every 3 weeks. It should be 3 weeks. It should be every 3 weeks. This is other drugs which may be used. And remember, if there is any allergy, then macrolides may be used in case of secondary prophylaxis. But till now, we use usually benzathine penicillin 12 lakhs units, more than 27 kg every 3 weeks. Duration, how long it should be given? if rheumatic fever duration is without carditis, if there is no carditis, only rheumatic fever, 5 years until 20 years of age. Which one is late? Suppose the age of the child is 12 years and you diagnosed as rheumatic fever, just like our case. So we should continue it up to 5 years, means 17 years, but second line is important, until 21 years of age. It should be continued up to 20 years. Okay. Second thing is with carditis, 10 years, or until 21 years of age. And with carditis, 10 years since the last episode, and until 40 years of age, possibly lifelong. যেখানে valvular damage আছে. Okay. So this is the duration of the therapy, and after that there is nothing there, but this secondary prophylaxis duration you should commit it to memory if there is any case of rheumatic fever. Jones criteria you should know. So we have finished. Now today is autism day, and you should know something about autism. I request Mandira to tell something about the autism